That's good to know. All right, hello everybody. We're going to go ahead and put together a presentation titled "The Co-Occurring Epidemics" and how COVID and addiction are interacting in our world these days. Next slide, please. So as you all, I am sure, are highly aware of, overdose is the leading cause of injury, death in the United States. There were over 70,000 deaths in 2019, 36,500 were due to synthetic opioids, such as fentanyl, primarily. So if you recall, 2019, we had the almost 72,000 deaths. If you recall, 2018 and 2017 gave us a degree of optimism based on the number of deaths that prior years, every year we were breaking the prior year's record in the number of deaths until 2017 and 2018, we saw a little bit of a plateau and maybe even a decrease then in 2018. But based on the data that continued to come out of 2019, it looks like those had increased. And from all data that we're looking at now, sadly, those deaths are sharply rising. Looking over the last 20 years, there's been over 700,000 deaths that have occurred due to overdose. The majority of those were due to opioids. 345% increase in opioid deaths from 2001 to 2016. And unfortunately, our state has led the country in deaths due to drug overdose, and we've led the country for most of the years now from the 2000s on. Next, please. This is a slide I just threw in there real quick. This is mental health symptoms during the COVID epidemic. During late June, 40% of US adults reported struggling with mental health or substance use. And you could see a 31% increase in people expressing anxious and depressive symptoms. You see a 26% increase in those who have expressed trauma-related or stressors and related disorder symptoms. 13% either started or increased their substance use per this survey, and over 11% have seriously considered suicide. What we know from national data, and I'm sure from all of your experiences, is that the rates of severe psychological distress and trauma have gone up sharply during the months of COVID compared to the previous year. And this should be very concerning for all of us. Next, please. When you look at overdose deaths, this is some reports that we were able to get for the first couple of months of the epidemic that came out. Here we could see that compared to 2019, March, April, and May. In March, there was an 18% increase in overdose deaths compared to March of 2019. In April, there was a 30% increase, and then May, there was a 42% increase. All incredibly significant numbers. Next, please. This is a report that came out this month that I wanted to share with you all. This is national data, and I'm gonna need to move my form there. Here we go. This is national data that looked at EMS. It's called the National EMS Information System, or Nemesis. And what this looked at was overdose-related heart attacks by EMS. And in 2020, there were over 25 million activations. And you could see that there was a sharp increase during April. And so you could see the oranges color line is the overdose from cardiac arrest. Sharp increase during April, 123% increase, and reaching the peak of 74 per 100 by May 4th. And then you could see those numbers have declined, but still remained elevated from baseline, remain elevated through the reporting period in August at a rate of 49 per 100,000. So overall, during that period of time, there was a 50% increase of overdose-related cardiac arrests compared to either 2018 or 2019. Next, please. You know, this is some staggering data that's come out of West Virginia. If anybody wants to look at the Office of Drug Control Policy, you could see the address there on the bottom where you can get pretty close to real-time data any day of the week regarding a number of these indicators. But I want to draw your attention to the right side of the panel there and the overdoses per month and year. This is not deaths from overdoses. This is responses, EMS responses to any overdose. And you can look at in May of 2019, there were 651 overdoses, and then you go down the list and look at May of 2019, there were over 1,000 overdoses. So a horrific number of increase in May of overdoses, and you could just kind of also see the rest of the months during that time that they were higher in West Virginia than past year. Next, please. This is a report that NIDA had funded, and what these researchers did was looked at COVID risk and then outcomes in patients who had substance use disorders. And they looked at over 73 million electronic health records. And of those electronic health records, 7.5 million had diagnosis of substance use disorder, 12,000 were diagnosed with COVID, and 18,000 had both. And some of the conclusions that were reached from this study, that having an addiction, having a substance use disorder increased your risk of having COVID and complications, serious complications due to COVID. So 10% had SUD, yet represented 15.5% of all the COVID cases. When you looked at which substances had been most associated with COVID risk and the complications, for folks with opioid use disorder, they were overrepresented, followed by those with tobacco use disorder. Like I mentioned earlier, not only were they more at risk to have the infection, but then also had worse outcomes, such as having to be hospitalized for a severe case of the disease, as well as dying. Also, health disparities wise, African Americans with recent opioid use disorder were 4 times more likely to develop COVID, which highlights the need to screen and treat SUDs as part of the overall pandemic strategy. So this is something that I've been trying to yell from the rooftops to get people to pay attention to the fact that not only are we going to be suffering in large amounts with psychosocial stressors, but having an addiction is going to put one at risk for having more significant complications and more likely to contract COVID as well. And we need to take these realities into account as we think about both public health prevention measures and resources to screen and treat. Next, please. So this is, there's 2 reports I'm going to share with you that looked at urine drug results, screening results during the pandemic. This is one that came out this year, of course, that looked at 872,000 specimens from January to May. Over 50% of these specimens were female, and over half were also 55 years or older. And what they determined from these urine drug screen results is that during the pandemic months, so March, April, and May, there was a 35% increase in fentanyl. There was a 44% increase in heroin and a 10% increase in non-prescribed opiates. What they also determined that a combination of fentanyl with other drugs increased, which is not surprising based on what we're all seeing in West Virginia, where most of the folks who are coming into us are polysubstance users with fentanyl and other substances that are combined with the fentanyl. You can see that of the substances that were combined with the fentanyl in these urines, 89% amphetamines, 48% benzos, 34% cocaine, almost 40% opioids, and 4% heroin. There were declines in non-prescribed gabapentin and benzos, which probably doesn't surprise me too much, given the fact that people had less access to their doctors, less access to pharmacies, and so would not have been given the same rates of prescribing of these prescription-controlled substances than they would have pre-pandemic, unlike the illicit substances such as fentanyl, heroin, amphetamine, cocaine, where you would see higher rates. Next, please. So this is another study that came out in July. The one I just showed you just came out, but this one is one that came out in July that looked at over 500,000 specimens, urine drug screens for non-prescribed drugs. And you could see that there were increases in fentanyl, 31%, methamphetamine, 20%, cocaine, 10%, and heroin, 12.5%. And you could see how those prior to the March COVID national emergency date of March 13th, you could see what the rates looked like prior to that, and then how they increased and climbed following. Next, please. So this is a national advocacy group, the Addiction Policy Forum, and they put out a survey nationally and asked a series of questions about how people themselves with substance use disorder and also family members of people who are struggling with addiction have responded during what they've experienced during the pandemic. 34% reported changes or disruptions in accessing treatment or recovery support, which again is not surprising considering the fact that a lot of treatment programs were shut down after the stay-at-home order, especially in different places of the country, residential treatment centers, intensive outpatient programs, group-based setting, et cetera. 4% reported an overdose since the pandemic, and highest reporting overdoses were in the South Atlantic region. And looking at the data and talking, just getting a meeting, I just had a meeting with the Addiction Policy Forum. I'm on their advisory board, and our state was overrepresented in that area with the number of overdoses. Interestingly, I'll also say this now, I attended the American Academy of Addiction Psychiatry, our national meeting virtually this weekend, and they were looking at the rates of overdose due to amphetamine. And it was pointed out that West Virginia was a big black area of highest rates of amphetamine overdoses, methamphetamine overdoses. So that was pointed out at this national conference. 20% indicated family members' substance use has increased because of COVID. Next. So when epidemics collide, this was a pretty interesting article that came out a couple of months ago by some of our addiction colleagues in the Annals of Internal Medicine. When epidemics collide, coronavirus disease 2019 and the opioid crisis. And these were some of the points that were made in this communication, that SUD patients are at greater risk of infection complications. And of course, we would all, if we took a moment to think about that, would understand why that would be so. One of the biggest reasons would be because of how people are using drugs. So if you're smoking a substance, then that's going to put your pulmonary organs at risk and make it more likely that you will succumb to infection. If you're injecting drugs, then that's also going to affect your inflammatory response and how the body is trying to respond to various infections and puts you at a lower ability to have an appropriate immune response. And not to mention that most of the people who are in active addiction will certainly not be taking care of themselves as a priority. The other thing is a point of how important it is to ensure uninterrupted care. And what I would argue is one of the big mistakes that the shutdowns caused was forcing people to isolate without taking into account how necessary it is to have uninterrupted connection and personal care for those who are suffering from psychological, psychiatric disorders, and especially addiction. They proposed that methadone delivery continue to be accessed, and proposed mobile teams for patients who were quarantined. They were in favor of telephone prescribing of buprenorphine, given the fact that not everybody in the country has access to a data plan or even has Wi-Fi to do virtual video care. Temporarily remove limits on the number of patients per prescriber. Expand mentors to help local providers. So actually, this was a recommendation that we have been doing in West Virginia, and actually what we're doing right now prior to the pandemic, which is trying to provide mentorship to those frontline workers throughout our rural areas and other areas in our state to be able to provide care to the people that they're seeing in their communities, and to give folks support and the confidence to continue to provide this care uninterrupted. And then the other recommendation that they were putting forth was eliminating all of the federal training requirements that SAMHSA has in order to allow ED physicians and hospitalists to provide enough medicine on discharge to establish care, enough really specifically buprenorphine or even methadone really to establish care. So as most of you know who've done the waiver training to be able to prescribe buprenorphine know that unless you have a waiver to be able to prescribe, that you cannot write a prescription for somebody to go home with medications in order to get them to the next appointment. So that was one of the recommendations. Next. So that ends my formal talk, and I would be happy to entertain any questions or comments or thoughts that you all have regarding this material or your own experience.
First, thank you so much, Dr. Berry, for putting together that presentation, and certainly was awesome and very timely for sure. So
I'm glad I did not disappoint you.
Never, never. But certainly open for any questions, comments, thoughts, like Dr. Berry said, or sharing some experiences. Feel free to unmute and just speak up.
One thought that came to my mind was the ideas of a culture of harm reduction versus a culture focused on recovery, and whether that's going to affect people being interested in treatment, you know, with all these high numbers. What do you think about that, Jim? Does the culture make a difference?
Yeah, I think absolutely culture makes a difference. And I think it's really important how we're messaging what we do and where we message it and what our priorities are. And so, yeah, I do believe that's going to certainly impact a lot of what we do going forward. I'd be curious to hear from all of you what your thoughts are, why it is that overdoses are increasing during the pandemic.
We've asked our people, and it's stress. The stresses on people are over, you know, they're new, they're tired, their finances or problems, all the, you know, stresses. And we're dealing with a population that, you know, as you guys do this, we all see that their coping skills aren't great when they start in recovery. It takes 18 months to 3 years before they start getting those coping skills. So if you're a week into, you know, your recovery, or a month, even 3-6 months, under a year, they reach back to what they know, which is, you know, this is how you deal with stress, or you deal with, you know, or boredom or whatever, family issues, other things, unemployment. So people are bored, they're unemployed, they're stressed, they're at home. And so what we saw, and again, it's anecdotal, but at the beginning, people seemed to be doing better because they weren't hanging out with other people that were, you know, potentially facilitating their drug use. At about June, that went away. August, it was bad, you know, and then now we're starting to see it worse. And so I think we're having to, you know, and adjusted on the ground, kind of putting in more control. Like you said, you know, how do we get people connected as much more as we can? And so I hope, at least in the end, that we're seeing, but these are even the people that are in treatment. You know, we're seeing only the people that are doing well, relatively well, and they're struggling, you know, they're relapsing. I mean, marijuana use is through the roof. You know, we're working on, you know, stop, you know, people are more anxious, they're making them paranoid, they're hallucinating, but marijuana use is through the roof. At the same time, I'm like, well, it could be a lot worse. So I find it hard to really push them. I mean, we're pushing them, but it's a balance. And I think that's what kind of, you know, also the other question was, you know, kind of the culture. And I think there is there a clash of recovery versus, you know, harm reduction culture? I think they can actually coexist. And I think our patients and our clinicians are smart enough to sort that out. But I do think there will be clashes because, you know, one's harm reduction, the other's, you know, kind of recovery and treatment. And I've struggled with it. How many people do I do on the phone? How many, if I saw your face, does that count? And then I call you back because that's much better. If I haven't established, I don't need, you know, the rules have changed. And I hope I'm staying within the lines, but, you know, at the same time, come get me. I mean, I don't think anybody's coming to get us, so I'm not worried, but, you know, we've started a lot more people on Suboxone through this. So it's opened up some opportunities. But I agree. And I think, you know, that's why I think there's more abuse. And I actually think I worry about some of the data because, like, here in the Eastern Panhandle, we can't test, well, we can test for fentanyl, but we can't test locally for fentanyl. It goes to Morgantown. So our panels don't even test for fentanyl. So I know a bunch of people that come in, they overdose, and their drug screens are clean. They're not clean. It's fentanyl. I haven't seen a lot of heroin. And so I think even that may be masking some of our data, because if we have that problem, I can imagine a lot of other hospitals and areas, you know, their machines can't do fentanyl, or they can't do that, or you have to send it out, or you have to remember to order a fentanyl test. And, you know, and our docs aren't thinking that way. They're just doing a drug screen, and, you know, they're, you know, not through any fault of their own, but, you know, 4 months later, they're saying, oh yeah, we should be testing for fentanyl. It's just not, it shouldn't be reliant on them remembering it. So I think our data out here would be interesting to look at, but I know we're under, under reporting fentanyl just because it's not being tested for.
Sure. Yeah, very good thoughts. What else? What else any other ideas of why the overdoses may be increasing?
I wanted to blame hope, or the lack of it, more than anything.
Okay. Yeah.
You can't really quantify it. When people look, I mean, when they decide to get into recovery, running out of money is the number one reason they come to us, and they get a stimulus check to avoid that. And then the other reason they come is, well, they have hope for a better life for themselves. And COVID is got this sort of gloom effect on everyone.
I think a lot of it has to do with the lack of actual human-to-human contact, not being able to be around other people and feel shared experiences. It's different via computer screen.
Yeah, I agree. I do think it's something different. There's something about being a human being that craves and requires being in the presence of another human being in order to live and function and deal with life's stressors and demands and pleasures and all of that. And that's been stunted these many months. Another idea that's been brought forth is that when you're using in isolation, you're not around somebody who might be able to rescue you from an overdose, whether it's with Narcan or, you know, just being able to do basic chest compressions or slap you in the face to get you woken up and all of this stuff. So that's another side effect of isolation that has been proposed.
Yeah, and that's interesting. One of the things that we try to keep an eye on that I've had trouble finding the last couple of months is the naloxone use and distribution and training. it seems like anecdotally, I haven't quantified it, but it's kind of fallen off, right? So it was a huge push to have prescriptions and everyone carry that's able. And if you're in recovery, then you do that. And now it's just hard to find information on it other than, you know, when we talk to our partners and our colleagues and our patients and communities, and it seems to have dropped off some.
Yeah, I've been wondering that too, and thinking about our harm reduction programs, our needle exchanges and Narcan distribution centers, and they've had to shut down during those times of the shutdown orders, et cetera, not being able to do everything that they would have done before too. I have to imagine too that we're going to see an increase in the rates of infectious disease over the next several months to year. Also.
What do you think about prioritizing our population that we're working with for COVID vaccines? I think we should. I think it's a tough sell because of the politics and stigma, but
I think so, David. I mean, if you look at the data I presented that shows that those with SUD and drug use are at higher risk for these complications, and you follow the data, then yeah, absolutely, they should be up there towards the front of the list as well as a vulnerable population. But like you've already acknowledged, it's going to be a tough sell for the policymakers because they, you know, this is a group of people that are, you know, not necessarily have a large voice or a lot of people who are advocating for them. I'm part of the Governor's Council for West Virginia on substance use disorders, and that's one of the things that I'm going to bring up because we have a council meeting this week or next week, and make that very point. We'll see where it goes.
can try.
Are there any other comments or questions or experiences anyone would like to share with the group? And feel free to chat in as well. I can read it off for you.
I noticed that there was some promotion of telephone only, and we had a horrible experience with that at Cabin Creek. I was wondering if anyone else had a positive experience with telephone only, not going into this dark hole of complete disengagement. It's what we ran into with it. No video.
Yeah, so Ryan, for me, it was more on the harm reduction side and getting people started. I agree with you. For doing the groups and maintaining and, you know, connecting, it's hard, but it's just as hard to do bad video as it is to do good phone calls because they're so disruptive, you know, and there's so much noise and there's the dog, you know, and people are showing you the ceiling and their floor and all kinds of stuff like that. So it is a challenge. But from the side of being able to pick up the phone, somebody who we haven't brought into our system, I can pull up their chart, talk to them, and I think do a fairly decent job of getting them started. I felt really good about that. I agree with you, the videos and connections and people not being there and fishing, you know, probably fishing, and we had a guy four-wheeling in group. I'm like, you can't four-wheel while you're in group, you know. You know, but I you know, but I do think for the people you're getting into treatment, the first visit, the second visit, you know, those very early visits from the ED or inpatient, I think those were valuable. That was kind of my experience.
And I have to say that I've been trying to look at some of the things that I've been able to do clinically that I was not previously able to do. And some of that is involving family members. So we run a multi-family group as part of our IOP. And we now have family members joining family group from all over the country where they never would have been able to participate in that before, which has been hugely valuable to them. And they've been very grateful for that, and we've been able to share resources with them as a result about things via Zoom that they can access for their own support. And once there were months of norming, as Dr. Baltira was talking about, like, you cannot do that in group, where before it was like, you couldn't do things in group that were fairly obvious, and now people are joining from crazy places, and confidentiality has really been a concern. Can we ensure that the person is joining from a confidential space? And I've observed providers having different ways of dealing with that. Dr. Marshallek is kind of like a drill sergeant, like, who's in the room with you? Show me your screen, show me your room, and he makes the person like show their screen around. And other people handle it slightly differently. But however you choose to norm the group, it's going to depend on the culture of that group. And once the norming process is complete, and it's ongoing, but once the group is normed, they help norm the new people. I have found that overall it has increased access, at least for those who do have internet and a device through which they can join groups. So that has been one of the positive experiences I have had.
I'm sure we could all hash some stories there, but you guys just jogged my memory from well before COVID. 5, 6, 7 years ago, as a pharmacist, I had a review of medicines phone call, and I couldn't help but wonder, in the background, all I heard was slot machines in Vegas, literally. And I, like, everybody's got a boss. So I had to gently ask, ma'am, I gotta ask you, like, are you at a slot machine or video poker? And she's like, oh, I'm at a slot machine. The reason I bring it up is it's probably one of the most impactful patient conversations I've ever had. She had a number of medication issues going on. That being said, a medicine review is not group, so I think I had it a little bit easier, folks. But, glass half full, lemonade or whatever she was having, so.
Let me bring up an issue that we had here, and I'm curious to hear how you all would respond to it. This was an issue we had today at one of our sites. Is during the group with the provider, one of the patients started nodding off on video to the point where he nodded off and just completely became unconscious into his hands. And I'm curious to hear, for those of you who are doing video or telephone, how you all would handle that. I'm surprised we have not had to handle that before, given all this time.
Sarah, was there something you wanted to add? Or an experience? No worries at all. I just noticed you unmuted.
You're quick. I was going to, but then I decided not to. Well, I was just going to say 911. You could do a well visit or 911. I mean, depending on whether or not they came back to. I mean, if it was a continuous, unconscious, or to what degree.
I had to yell at a patient
Or
once
did they just
already.
stay unconscious?
What was that, Sarah?
Did they come back to you, or did they remain unconscious?
Well, I'll continue the story. I want to hear what you all think first.
I'd probably call 911.
I yell at them until they wake up and tell them they get no medicine if they don't stay awake.
Yeah.
What if they never wake up?
Then I'm probably forced into 911, yeah.
And I think that's a tough one though, because are they awake or are they overdosed? Or are they just sleeping? And so you're going to call the police. And again, I would call if they're really out. I would call, but are you going to call the police on this person? Go to their house, get them arrested? All this stuff. It's not that black and white. I think it's a tough one. I don't know. I'd like to hear what they ended up doing, but I guess it depends. If they fell out of their chair, I'd call 911. If they were still sitting up and breathing, I'd probably call their friend to go get them, or even one of our outreach teams. We do have outreach teams, but it's tough.
you would be able to assess that, you know, if you had been in the group and talking to the person to be able to make that call. Hopefully it wasn't right off the bat.
Yeah, what about, let me ask you this. If you're doing a group like we are now, how would you handle that? Would you say something in the group? Would you immediately boot them off?
Well, I would call their name and try to get them to respond initially. And then if they did not, I would boot them off and call them.
I wouldn't want to lose connection with the person that was unconscious though.
Automatic breakout room, nap room.
Have everybody else in the group start applauding so they wonder what they missed.
That's very creative. I like that.
That's very creative. Yes.
I almost wonder if we need to have the Zoom room set up for the automatic breakout room, so if that were to happen, we could put them in there and still see them.
That's interesting.
Yeah, I like that idea because, you know, you can't really not watch that. You know, kicking them out, you can't watch them. But again, having used other platforms that's not Zoom, you can't do that with some of our other platforms. You know, with video, you really can't. And so but that is a good idea. Do you just put them in timeout? I don't know.
Well, I think one of the benefits of the COPE model is often, at least the way we currently run it at Chestnut Ridge and our other sites, is these things typically get identified in med group, although not always. If someone then, you know, is looking much sleepier in therapy group, and the case manager and other team members or the medical assistant can be very helpful in either removing them into another room if that's available or calling them. That's often what we do. Is I will, you know, private chat the case manager or the medical assistant and say, hey, can you remove that person and call them? And if they are non-responsive, you know, and we're really worried, then we could call 911, because as a single provider, you cannot manage a group of 10 people and someone who's non-responsive at the same time. You really need help with that.
Yeah. So what ended up happening, and I wasn't part of it, so I just got word about this, was that the case manager immediately logged this person off and then called them to see if they were okay. No answer. At that point, decided to call the police for a welfare check and gave the address that we had on record. Went to the patient's father's house and the patient wasn't there. Then what do you do? Right? So then got word back, and then it was trying to hunt down, okay, well, where could this patient be? And I believe what happened is they found out that he was at a girlfriend's house, was able to call the house, and from what I understand now, the patient is in the emergency department, but I don't know how they got there, whether the police went there for a welfare check or the girlfriend got him to the emergency department. I don't know, but that's how that ended.
How do you guys feel about not prescribing to someone who's grossly intoxicated and making them come in the next day, or you know, do another meeting with them the following day, both to discourage behavior like that, but also as a safety issue?
It's a good question. Yeah, I'd be curious to hear people's thoughts.
I think that's kind of like with the policy with the benzodiazepines, you know, either daily dosing or continue coming in until it's out of your system. I think I would do the same thing, not prescribe it at all until they were not intoxicated. And even then I might be leery of even continuing it if you know, if they weren't, you know, if they had other things in their system, and I might refer to, you know, a higher level of care.
Okay.
Yeah, I struggle with that one because I tend to err on the other side of giving people the medication, because they're already, you know, the risk of them overdosing if they don't have their Suboxone. So I guess it would depend how out of it they are, or how. So I think it's a tough one, because I mean, you know, if they don't come back and they go out and overdose, you know, I think the benzos are a little harder, but you know, Suboxone's not likely to overdose them if they're on other drugs. You know, it's just, we have people that won't treat patients on fentanyl. And that was, you know, we can talk about that a little bit later. I have some questions about that, but you know, is it harm reduction, or is it, you know, treatment, or is it both? So.
I mean, disclaimer, I'm not a prescriber, so this is just opinion, but
you have prescribed a lot.
this is true. But I personally, like from my perspective, I would recommend like them coming in daily, and I would try to get them inpatient for detox or some sort of residential before like continuing like doing more than a day or two of medication.
Yeah, what I've generally done in the past is if I see somebody who's obviously intoxicated, I won't give them Suboxone. I'll make them come in the next day and say, listen, you know, they'll fight me again. I've had people, when we were in person anyway, really fight tooth and nail to do it. And I said, listen, you know, just because you come here doesn't mean that we're automatically going to dispense a medication to you. I want you to come back when I could actually have a conversation with you, and that you're coherent, and that we could talk about the risks and the benefits. And I am more than happy to make sure that you get a medicine tomorrow if you're in a right state of mind to be able to do this. And so that's generally been my policy. With a group, it's kind of tough to not do that too. And people, you know, other patients in the group, if they see that, you know, it doesn't matter if somebody's coming in and on the group Zoom and looking intoxicated, and we don't address it, or we just get the prescription without having to address it, then that's also defeatist for them. And, you know, it feels like it doesn't hold them as accountable for their own recovery when that's happening too. So it can really have a negative effect in a group setting.
Dr. Morrison, I noticed you also chatted in saying avoiding med emergency and telemed groups. Did you want to expand on that as well, or an experience you had? I think you might be muted.
Yeah. Dr. Carter made me do this. I didn't want to do it. I thought it was a waste of time. And we haven't had that happen the way it happened to Dr. Berry with the person nodding out on the call. But we collect each and every person's location and write it down at the beginning of every med group call. And so it's been, for us, a lot of work that never paid off, but it would have paid off in this one situation. We did have an in-house person have a seizure once, though.
I mean, it's a smart way to do it. But it is a labor-intensive way to do it. So Dr. Morrison, do you do that yourself, or is the case manager doing
Case
that?
managers, yeah, they organize the calls, and when they're first logging on, they get all that data down.
Yeah, that's something we've talked about doing today after we had this this discussion earlier.
Well, thank you all so much for sharing the experiences and comments and everything. We have about 8 minutes left, but were there any other thoughts that anyone wanted to share with the group?
Any wisdom on inducing people that are using fentanyl? I'm on a few listservs for pregnant women, and they're talking a lot about admitting people and all this other stuff. I haven't faced that, but again, my N is small, so I think it, you know, varies, but probably how much people, and I've had people, you screen them for fentanyl and they're sky high and they're doing fine. You have other people, you know, and so it doesn't correlate very well, levels or anything. So I've been inducing people outpatient generally, but nationally, there's a lot of caution in putting people in the hospital and microdosing and the Swedish method, you know, all these other things. And I don't know if I should, am I missing something, or is it just depend, and most people are going to be fine, and occasionally you're going to have a patient that's more difficult and may have trouble? So any wisdom on that?
I'll just say a couple of things, and I'm curious to hear what other people have to say. But if we were going to induce everybody who was on fentanyl in the hospital, our hospitals would be full, and we wouldn't be inducing anybody because everybody is coming to us on fentanyl. So that is just not realistic, nor I think necessary. I haven't had a lot of, I've had a handful of problems with some people that that have had some precipitated withdrawal who have been using fentanyl. I know my colleagues, probably then what you've seen on your listserv too. So there's been some colleagues out east who just have had a really hard time transitioning people to buprenorphine while they've been doing fentanyl. And I just haven't, again, I've had it a couple of times happen, and for me, it's still, you know, wait until you are in good, sick withdrawal and then start the medicine. And if you're in good, sick, and withdrawal, then this should make you feel better. It may not. There's a small chance it can make you feel worse, but then we're going to have to deal with that at that point. Now, I do know Dr. Husted has transitioned some people who have been on long-acting opioids that have been prescribed and using the microdosing method with buprenorphine, and has had success with that, but he's been doing that inpatient. If Jeremy, if you want to speak about that.
Yeah, it's always been with methadone people, so obviously we're not keeping people on fentanyl and then microdosing on Suboxone. I think people do get a little bit sicker maybe because people that have not historically had problems jumping on to Suboxone seem to have a little bit more issues with it. But again, if you wait long enough, you know, people get sick enough, usually you can pull it off. I mean, you can do that with methadone too. It's just miserable and takes days and days. But the whole microdosing things work pretty well for methadone. I haven't really messed around with it again for some of the other stuff because we're not keeping people on the long-acting ones that then put them on Suboxone. Yeah, the methadone and the Suboxone thing is worked pretty well. So we're on a third person right now. It's going well each time. So fingers crossed.
Are you guys ever using buprenorphine without the naloxone to get people that are difficult to get induced as outpatients?
I have not.
I did it inpatient a couple times just because we have control, but I haven't done it outpatient.
We have a few minutes left. Any other thoughts or comments? Dr. Baltiera?
Yeah, everybody who's on Suboxone will have naloxone in their urine, correct?
They should.
Because I've got one lady who I suspect is selling, you know, she had a rash, all that, for Subutex, we'd give it to her, and she's negative, but I think she's selling her Subutex and taking Suboxone, or
vice versa.
Yeah, vice versa, yes.
Yeah.
Selling her Subutex and taking Suboxone. She shouldn't have any naloxone in there unless she's taking Suboxone. So I was like, so we had to let her go, but.
Yeah, they should.
Right.
Unless there's some strange metabolic reason or medical condition why that would not be the case.
Right. So.
I've never seen a confirmation that didn't have naloxone in it, so there's definitely some that's absorbed.
Right. Got it.
Mithra, are we going to be rebranding the name of this too? Are you going to mention that?
Yeah, so we certainly are. I was going to say that in the announcements, but it might be great to bring it up now in the last couple of minutes and get everyone's thoughts. So thank you for reminding me of that. But due to popular demand, we're going to be kind of rebranding the name from the MAT Echo to Substance Use Disorder Echo. So nothing with the content or anything will be changing. It's just a more fitting title for the project. So if you see that in recap emails or reminder emails, it's just going to be this group that meets from 4 to 5 today. So yeah, that was due to popular demand. So if anyone has any thoughts, feel free to just share with us now, I would love to hear your thoughts on that.
Yeah, and as a plug, I mean, this is something I advocated for, just to really get at the reality that we're not just addressing one drug, and we're not just using one modality, but what we're trying to help folks with on these calls and help ourselves with on these calls is a learning community that is going to help providers and support staff be well equipped to treat addiction as a whole. And the substances will change over time. The therapeutics will constantly, hopefully, evolve and get better. And that's what we're about.
Thank you, Dr. Berry. And I will say, Dr. Houston also made a great comment too, that SUD echo, if you say it phonetically, kind of sounds like Sudoku. So that was another positive. We're all fans of Sudoku. But, all right, it is 5 p.m. now. Dr. Berry, thank you so much for that awesome didactic. I do use that word a lot, but it certainly was great. So thank you so much. And thank you all so much for joining us today too. It's one of my highlights of my Mondays. So I really do appreciate each and every one of you. And the work that you do is very inspiring to me. So I will just say our next session will be on January 11th, 2021. So this will be our last session of 2020. And Dr. Zhang is going to be talking about sleep studies in MAT patients. So keep an eye out for that reminder email. I do encourage you all to continue submitting any cases or questions throughout the holiday season. And I wish you all a really safe, warm, and happy holiday season and a happy new year. So thank you all so much. We'll see you guys next time.
Happy New Year, everybody. Merry Christmas.
Thank you.